Hi, everybody. This is Jen Kovich-Bordenick from the eHealth Initiative and Foundation. Welcome. We're just getting started with our webinar this afternoon on leveraging the HL7 FHIR standard to drive improvement in clinical care. And I want to welcome everybody today. It's a cold and breezy day here in Washington, D.C. We're excited. We've got a great group of speakers this afternoon and a really interesting topic. So let's go ahead and get started. If we could go to the next slide, please, Kaylee. Thanks. So I'm really excited to have three wonderful folks here today. Good friend, Russ Lefwich from InterSystems, Dan Gottlieb, who's also from InterSystems today, two real experts on the FHIR topic, and then Laura Hierman-Langford, who's with the Homer Warner Center for Informatics Research at Intermountain Healthcare. Really excited. And what we're going to do, we've got a couple of different presentations we're going to go through, and then we've got lots of time at the end for Q&A. Next slide. Couple of housekeeping issues. Everyone is currently muted. If you'd like to ask a question, and we do want you to ask as many questions as possible, go ahead and submit them through the chat feature there at the bottom. You'll see a little Q&A section, and you can go ahead and enter your questions right in there. And we would be, we'll hold them all until the end, and then we'll get through them one by one. If you're interested in a copy of the slides, we will post the slides on our website, www.ehidc.org. And Kaylee, who's on the line with us right now at EHI, will also send out a link later today if you're looking for those. If you're having any technical difficulties, just let us know through the chat feature right there. And again, we're already getting questions about the slides. The slides are available and will continue to be available online today. Russ, everybody's very interested in your slides, so it's a good sign. So a couple of quick points for those of you who aren't familiar with the eHealth Initiative. We've been around for 18, 19 years now, and our mission is to serve as the industry leader. We primarily convene executives and talk about best practices and how to transform healthcare. And today's a great example of that. We do research, education, advocacy in a number of different areas and try to figure out how can we transform healthcare. And FHIR is a really important piece of that. We've got a wonderful membership with stakeholders from across the healthcare spectrum. Here's just a sampling of them. If you're not a member of eHealth Initiative and you're an executive and would like to be engaged, we have a wonderful group and we would love to welcome you into our tent. So please reach out to us. As I mentioned before, payers, providers, consultants, vendors, patient advocacy groups, all different sorts of groups. Meeting around really critical, important issues. And we've got a number of really interesting initiatives going on right now and work groups that are meeting, and this is just a sampling of them. We've got a number of different work groups and steering committees, advisory boards looking at analytics, data governance, privacy, and non-HIPAA covered entities. We have a pretty significant effort looking at prior authorization right now in healthcare. We're doing a lot of work around artificial intelligence on healthcare. In fact, we've got a great webinar coming up next week on that, if you're interested in that as well. And we have Kaylee's running a LinkedIn conversational discussion online right now around AI as well. So that's something, if you're interested, we'd love to have you get involved in. We've got a number of initiatives around opioids and medication adherence, and a lot going on around population health, and I think we're going to touch on that today as well and how to use FHIR in that. Next slide. And all of this, we are a nonprofit, so all of this, everything is out there in the public area and arena for you to tap into. We have an eHealth Resource Center available online, ehidc.org/resources. There are hundreds of reports, survey results, best practices, case studies, in all of those different areas available to you. And this is a great source of information if you're looking for a paper, a data point, a blog, an interview, anything. It's all available to you right now. And the great thing about the Resource Center is that you can upload your reports and stories and case studies as well. So please go to ehidc.org/resources and check that out. And I do want to thank InterSystems and Russ for their wonderful support of this event today. As I mentioned earlier, we are a small nonprofit, and if it weren't for generous organizations like InterSystems, we wouldn't be able to bring these types of educational programs to you. So thank you, InterSystems. We appreciate that. And I'm going to actually turn it over to Dr. Lethwich now, who's going to take us through leveraging the HL7 FHIR standard to drive improvements in clinical care. And we've got, as I mentioned, a really great presentation set up for you. So Russ, I think you're going to drive this part of the presentation. Are you all set there?
Yes.
Okay, great. Take it away.
So Russ, are you pushing the share on your computer?
Yes.
There we go.
Okay, thank you, Jen, and good afternoon, everyone. So I'm going to start us off by talking about FHIR and the concept of FHIR without being too technical. And why there's FHIR. And then Dan is going to talk about where we are building out FHIR as a standard, and talk a little about looking forward ways to the future when FHIR for population health will be a next step in the FHIR standard. And then Laura is going to talk about the experience that Intermountain Healthcare has had implementing FHIR, and they're probably as far with FHIR implementation as any organization. And she's going to talk about some of the real world experience in using FHIR for decision support and clinical care. And to me, clinical care and improving care is sort of the flip side of population health. It's managing the population one individual at a time. With that, I'll talk about, get everyone on the same page with the concept of FHIR and what it really represents. So to do that, I'm going to go back a few decades to the 1980s when interoperability in healthcare data really got started. And the reason it got started was hospitals started to have more than one system in the hospital. It wasn't about exchanging data with other organizations. It was about the increasing number of systems that were within the walls of a hospital. So a few years ago, someone noted that the average hospital in the US had 80 systems or over 80 systems within its walls. So that the first need for interoperability is still at home. And in the current era, things have changed a lot, and there's data about individuals many places besides hospitals. The pharmacy has data, the payers have data, home care systems have data, genomic sequencing labs have data, individuals have data on their own mobile devices. And I would suggest that the meaning of interoperability has really changed. And now interoperability means being able to be in one place and see all that data for an individual or a population and see it in real time, as we do with other domains on the internet. And not only is there data in more places, there's a lot more data now than there was 3 or 4 decades ago. On the screen now, you see a graph that is a adaptation of a graph created by Dr. William Stead at Vanderbilt a few years ago that estimates the number of facts that exist for every complex decision we make in healthcare. Not all of them are complex, but they're all getting more complex. And in 1980, he estimates there were about 10 facts per complex decision. In 2018, if you extrapolate, there are about 700 facts per complex decision. And in 2020, there will be 1,000. Now, the other line that's important on this graph is at the number 5 because that's the number of facts that a human mind can handle in making a decision. I like to think I can do 6 or 7, but I was behind in 1980, and now I'm really hopelessly behind. So with that view of the increasing complexity of data and distribution of data, HL7, the organization, created a new standard, and it started about 8 years ago when there was a task force that HL7 asked the question, what if we created a new standard from scratch? What would it look like? And that task force came forward with the concept that we now call FHIR, Fast Healthcare Interoperability Resources. And they did this with the recognition that the existing HL7 standards, HL7 version 2 was almost 30 years old, CDA was over 10 years old, and those standards are going to be around for a long time. I'm not saying that FHIR is going to replace them, but they don't do this, they don't answer this need to get data from multiple sources and see it in real time, nor to query that data. And there's an increasing trend toward data transparency. Things are moving from offline to online. And so that was the inspiration for FHIR. And what FHIR is in its essence is a representational state API or a REST API. Now, REST doesn't refer to relaxation or sleep. It's a computer concept of representing the data on one computer on another computer in its current state. It's the basis of most things we do on the internet, Google and Twitter and Facebook. But the easiest way to explain it, I think, is your favorite travel website. And say you want to go from Boston to London on November the 20th, and you type that into your favorite travel website, and in a few seconds you see a list of flights with a departure time, a price, and so forth. And that works not because your favorite travel website has downloaded all the airline schedules. It works because the airline industry has agreed on how to represent the data in an airline flight. So that is what FHIR is for healthcare. It's both the same technology as those airline sites, and it is the meaning of the data in healthcare. And that's where it gets complicated, because obviously the data in healthcare is a lot more complex than the data in an airline flight. So let me explain a few concepts that are important to understand for FHIR. The first one is what is known as FHIR Resources. And this is resources as in a URL. Remember, that stands for Uniform Resource Locator. So those resources, that data in FHIR has a known location, and it looks like a URL that tells you that data is on a server somewhere, maybe on your server, maybe on another one somewhere. And it has a defined meaning, and that's what the FHIR specification is. The FHIR specification in human readable form tells you what that data, that piece of data, that FHIR resource means. And each FHIR resource is a logically discrete data concept, not a data element, but something a bit larger. So some of the ones as an example are the patient is a FHIR resource. The medication is a FHIR resource. Family history is a FHIR resource. Everything that would be in a family history. Some of the resources are what we call infrastructure resource. So there is a list resource, and whether you're using it for a list of medications or a list of patients that a provider has in the hospital, it uses the same FHIR construct, the same FHIR design to represent that. Another FHIR resource is a document resource. So you can create documents that contain data in FHIR format, just like a CDA document, except that the data is specified as FHIR resources. A care plan resource, which in fact is not a document, but is the connector, the organizer for the data that would be part of an individual's care plan. The second concept that's important to understand FHIR is FHIR Profiles. So a profile is built for a specific use case. It's all of the FHIR resources that are necessary for that use case, the FHIR extensions, which is a way of defining data that's not part of the standard itself, and the constraints like the vocabulary or value set bindings for that particular use case. And in fact, profiles are important because interoperability comes from using the same profile to represent data, not from just using FHIR. So interoperability with FHIR is in shared profiles, using the same profile. The other concept that's important for FHIR is that FHIR can be used in different paradigms of interoperability, not true of any existing previous standards. It can be used as a RESTful interface, as I've mentioned. It can be used to construct documents. It can be used in messages like HL7 v2 messages to send data from one system to another. And it can be used in services like decision support services. Just as it is, you don't have to transform it to make it computable. It's computable as it is. So we say that true interoperability means that we exchange information and it means the same thing. Now, if you think about that, what that statement is saying, it means the same thing not to the humans, but to the two computer systems that are exchanging the data. And that's an important point because humans are better at some things than computers are. And let me, as an example, say that two individuals had never seen the animal that you see on the screen. And one of them says, it's a black horse with white stripes. And the other one says, it's a white horse with black stripes. Well, anybody would know, even a child would understand they're talking about the same thing. They're talking about a zebra. But in fact, to computer systems, they don't know that those two individuals mean the same thing. A computer system has to have a very distinct definition or description of a data concept to understand the meaning that another computer system might have. And we call those descriptions clinical information models. Clinical information models are formal descriptions of data, the rules, the relationships between the elements in that data and the constraints, the value set bindings, the code systems. So that starts to sound a bit like a FHIR profile, and in fact it is, because a FHIR profile is really an implementation of a clinical information model. So have we used clinical information models before? Well, we didn't talk about it so much, modelers did, but we used them in clinical care as documents. So a clinical document gave us a reference to what the data, the relationship of the data in that document was. So you took a history and physical and cut it up into individual data elements, and you have one that says diabetes. Well, you don't know whether the patient has diabetes or that's something that their mother had and it was in the family history. So those relationships of the data in any specification or data are important. So we have to represent those in FHIR in a different way, and we do that with FHIR profiles. So say we had a profile for a procedure, and whether it was a laboratory procedure or a surgical procedure or an imaging procedure, all procedures sort of have the same elements, and they would be represented as separate FHIR resources that point to one another. So every procedure has a patient upon who it's performed and a condition that's the reason it was performed, a practitioner who performed it, an encounter that it's part of, and a diagnostic report that is the results of that procedure or the outcome. So those are the essential concepts in FHIR without being technical. But at this point, people sometimes are thinking, well, FHIR is just a draft standard. It's not fully baked. It's not being used. Well, it is being used, and we're going to tell you about some of those uses. And the other thing I think is we sort of have to change our concept of standards maturity, which used to mean that a standard was fully baked and people had tested it and it could be used. I think FHIR, there's sort of a new concept that I'll call the iPhone model of maturity. So we're right now at the iPhone 3, but people have bought it and they're using it because it can do things that they couldn't do before. And we know that the iPhone 4 and the iPhone 10 will be far better. And so it will be with FHIR. As each release comes along, there will be new features and new capabilities. So now I'm going to turn it over to Dan Gottlieb to talk about some of what has been done to build out FHIR.
Great, thank you, Russ. So Russ talked a little about the FHIR standard itself, and I'm going to build on that and talk about 3 standards that are starting to be adopted that really integrate FHIR into clinical workflows. The first of these is a standard called Smart. It's sometimes called Smart on FHIR, which is really enabling FHIR to work for app use cases. And to do that, and those apps can then run connected to clinical systems in kind of a plug-and-play way, where they can work across different systems. And we'll talk a little bit more about some examples of those. And so Smart builds 3 things on top of FHIR. The first is a concept called user authorization, using a standard called Scopes, based on with a standard called OAuth 2.0. And that, for example, if you were launching an app, it provides a way for the app to negotiate with the user around which data the app is allowed access to. So you launch the app and the app says, I want to access specific FHIR data elements, and then the user is able to allow or deny that access. The second thing that Smart builds on top of FHIR is support for single sign-on. So if, for example, you're in the Cerner EHR system and you launch an app, you don't, as a user, want to have to then log into the app. And so the Smart provides, by a standard called OpenID Connect, a way for that EHR to pass the user's credentials along to the app. Similarly, if you launch the app from within the EHR and you're working in the context of a particular patient record, you don't want the app to ask you which patient do you want to work with. You want it to be able to pull that information in from the EHR. And so Smart provides a way for context passing to happen between the EHR and the app. And one thing I think is worth pointing out is when I keep saying apps, a lot of people think of phone apps or tablet apps, and that's certainly one of the use cases. But Smart apps are often web-based apps that run embedded within EHRs also. And we'll look at some examples of both of those. And I wanted to mention that while Smart allows access to any data that's exposed by a FHIR, many of the current Smart implementations focus on the common clinical data set, a set of data elements that the Department of Health and Human Services put out, largely structured data. And so often those are the data elements you'll be able to access today through Smart. Of course, this set of data is constantly increasing in the different systems. So I wanted to start by looking at patient-facing apps. So these are apps that a patient may want to connect into a clinical system to access their data from an app. And the flow works kind of like this. The app makes an initial access request to the clinical system. In this case, we're going to assume it's a patient portal. And then the user is prompted to log into that clinical system to authenticate themselves. Then they use that authorization negotiation we talked about before to allow the app to have access to the specific data elements the app requested. If the user authorizes access, then the app gets an access token that it can use in those FHIR REST API calls that Russ was talking about to pull FHIR data into the app. And a great example of this is the Apple Health app. So this app ships with iOS, the version of this app that shipped with iOS 11.3 supports the ability to pull in your health record data from several hundred healthcare institutions in the US, as well as recently lab data from Quest and LabCorp. And the way that Apple was able to do this is they didn't go to each health system and say, please run our proprietary code on your servers to provide access to our app. Instead, the health systems support Smart on FHIR in their EHRs, and Apple supports Smart on FHIR in their health records, and therefore they're able to talk to each other without having to do custom integration each time. And if you don't believe me, if you actually have the Apple Health app, you can scroll down in any observation and you'll see there's a button that says FHIR source data. And if you click that, you actually see the raw FHIR data models that came through this connection. So they're really using these open standards to create kind of a plug-and-play ecosystem for this app. Another really great example comes from the National Institute of Health, which has a research project called the All of Us Initiative. It's part of the Precision Medicine Initiative. And the idea there is that they're trying to get clinical data on 1 million patients in the US so that we can do large-scale research studies. And one of the ways that they're collecting this data is using Smart on FHIR to enable patients to donate their data to the research database by creating a connection, by authorizing a connection between the health systems and the research databases. And so they're using Smart on FHIR to do this, and the really neat thing about that is that while the NIH is able to do it, you're also able to do it. So if you're running a research study and you want to give patients the capability to donate data, you can use these same Smart on FHIR interfaces to plug into hundreds of health systems that have implemented the standard. And then the last kind of patient-facing concept I wanted to mention is a service that CMS is providing to enable Medicare recipients, Medicare beneficiaries to connect apps to their claims history. And so this launched just a few months ago in 2018. And so it's a fairly new initiative, but it's enabling developers to build apps that can make clinical recommendations to patients based on their data history. And just like in those other examples, CMS didn't go out and create a proprietary standard that developers have to build to, but rather they're able to use Smart on FHIR to use these standard open web-based APIs to plug into this Medicare data set. And so now I want to shift gears a little bit. We've been talking about patients getting access to clinical data, but providers at healthcare institutions also want to connect apps to clinical data. This is a quote from a research study that I was involved with where Class Research interviewed a number of clinicians. And this is a quote from a clinician who said, we had this wonderful population health tool, but we couldn't get the EHR system to interface with it, so we had to enter information by hand. We just had to give up on that because we couldn't physically keep up. And so this idea of being able to connect multiple systems into clinical data is really one of the core principles that Smart is trying to enable. I'm not going to go through the flow on for Smart for the EHR launch flow for clinicians because it's very similar to the patient launch flow. The key difference there is that often clinicians will start from within the EHR to launch the app rather than starting from an app and connecting into the EHR. I also wanted to point out that the apps I'm going to show in just a minute are all, you can find out more information on them in the Smart App Gallery, which is at apps.smarthealthit.org. And the Smart App Gallery has a really cool feature called Try App, which means that for many of the apps, they use these open standards to enable the app to connect into a sample data set. So just like the app can plug into different EHR systems, it can also plug into the test system within the app gallery so that you can actually try out live versions of many of these apps. And the first app I wanted to highlight is an app called Meducation. It was built by a small company that was later acquired by First Data Bank, and it provides medication instruction translation. So if a provider speaks English and a patient speaks Mandarin, they're able to translate their medication instructions into Mandarin and hand it to the patient. And the reason I wanted to point this app out is the commercial app that hospitals purchased, and the app existed before Smart on FHIR was widely deployed. But in the early deployments, they did a manual integration where each hospital system involved a substantial amount of work to connect the app into their healthcare institution. And now that they've switched to Smart on FHIR, they've been able to get integration time that was in the span of months down to days in many cases. And they've done over 50 Smart on FHIR integrations into healthcare institutions. So it's an example of how these open standards can really streamline integration processes in the real world. The other example I wanted to give of a provider-facing app is an app developed by Duke Medicine for a research study. The researchers wanted to find out if patients perform an exercise with their medication, does it increase medication adherence down the road? And the reason I wanted to highlight this app is that what the researchers told us is that if they had to build this app using proprietary EHR APIs, proprietary EHR programming interfaces with developers certified for that EHR, they would have been cost prohibitive and they wouldn't have been able to do the research study. But because they were able to hire developers who could use these open standards, and the open standards are based on common web-based technologies, they were able to build the app at a low enough cost that they were able to do the research study. So I think it's a great example of these open standards enabling apps to exist that wouldn't otherwise be possible. I won't go into this last example too much in the interest of time. It's ClinDat is a research prototype developed by a rheumatologist. And what I think is neat about it is that it's a different way of providing a user interface into an EHR that this clinician was able to experiment with because open standards enabled him to plug into his existing EHR. And there's a lot of other really great examples in the Smart App Gallery. I encourage you to take a look around. I think there's over 100 apps now, mostly clinician facing. So now I wanted to switch gears. So Smart is a fairly widely used standard. It's been deployed in a number of major EHRs as well as clinical systems like InterSystems HealthShare to date. But there's a couple issues with it. So one of the challenges with Smart is that the provider has to remember to look at the app in order to be able to gain the benefits from it. And so CDS Hooks is an earlier stage standard that's just about to start rolling out into clinical settings today that kind of covers that gap. It focuses on ways to incorporate external advice into clinical workflows. So if a provider performs an action in an EHR and there's an app that's relevant, or there's advice that's relevant, or there's a suggestion on a different thing the provider could do at that point, CDS Hooks provides services with a way to surface that information into the provider's workflow. As I mentioned, it's kind of just approaching the 1.0 version, and it's just starting to be rolled out by EHR vendors. So in the CDS Hooks flow, the user would perform an action in the EHR, and so that could be something like opening a new patient record or starting a medication prescription. And then the EHR will call out to all the services that have registered handlers for that action. And then the service has the option of querying using Smart on FHIR, using Smart as a security method and FHIR as the API to pull additional information from the EHR, for example, a patient's lab history. The service can then decide whether it has a recommendation for the provider, and if it does, it can pass back information in the form of a card that will show up in the user interface of the EHR. And a great example of this is a research prototype from Boston Children's Hospital Computational Health Informatics Program. They wanted to create an alert that fired when a provider prescribed a drug azathioprine, which is used in organ transplant patients. And patients who have a particular variation on an enzyme will metabolize that drug differently. So they might need a lower dose. So in this CDS hook, when the provider goes to make the prescription, the EHR calls out to this pharmacogenomic service. And if the patient's genetic data indicate that they should have a lower dose, it's able to present a card to the provider with that recommendation. And what's really neat about this isn't something that's not possible today. The thing that CDS Hooks adds with FHIR and Smart and open standards is the ability to write this service once and then plug it into a number of different clinical systems without having to customize it at each site. And then the last standard I wanted to talk about is at an even earlier stage of maturity than CDS Hooks. It's currently in the standards development process, which means that it's a great time to get involved if you're interested in shaping the standard and doing pilots, but not quite ready for production use yet. And that's an effort called FHIR Bulk Data, with the goal of really making FHIR work well for population level data, for large data sets. And so there are a lot of examples in healthcare where we move around large data sets on a large number of patients or a large number of observations. A couple examples that came up recently was a large academic medical center that was syncing progress notes, so patient data every night, from a third-party clinic into their main EHR. So they had data on potentially dozens of patients who are seen every day and wanted to move this around. Another similar example within a healthcare institution might be moving data from an electronic health record system into a population health system, like a care management system, in which case you might want to backfill large amounts of data on patient's history into the other system. A really common example that's becoming more and more common is around creating large data sets, large extracts from an EHR or from a clinical system for machine learning. So you want to develop a machine learning model on a large data set. So in all these, and there's many, many other examples around moving data between payers and providers, moving data into clinical data warehouses, submitting data to registries. And in all these cases, you run into a challenge, which is that FHIR is really great at moving data for a single patient or for a small group of patients, but it's not really designed to move data on thousands or potentially millions of patients with potentially billions of data observations. And so the way that's done today is often use it in a manual way, where each system that's sending and receiving the data needs to map into a proprietary custom data mapping. Often it's comma-separated value files that get moved around. Meanwhile, we've spent all this effort developing really great data models in FHIR, really great programming interfaces, and really great security models. And so the FHIR bulk data effort is an effort to leverage all that work for these large data use cases. And so it supports queries that return all data on patients that a client system that's accessing it has access to. You can return data on just patients in a particular group, like a care cohort, or data for patients who are beneficiaries of a particular payer, or even all data in the system. So if you're moving between one EHR vendor and another, you might want to extract all the data from one system and move it into another, and you might want to use FHIR to do that so we can leverage all this great work that's been done in the FHIR world. And there's different filters that you can also apply using this API, using this programming interface around things like restricting just the types of FHIR data models that are provided. And I'm not going to go through the flow here in a lot of detail, but I think the key point to understand is that this is really for machine-to-machine communication, where there's not a human logging in the middle, but you might have a nightly job that pulls data from one system and moves it to another system. And I put together a quick example of this. This is based off of some synthetic data, some fake data, and I loaded about 1.5 million patients into Google's BigQuery service. There's nothing magic about Google here. This was an example of a type of service that could do these large queries, but of course other vendors, including InterSystems and Microsoft, have similar systems. In this case, there were about 53 million observations across 14 million encounters. And what was neat is that this data, because it's in FHIR format and I loaded it through bulk data, in this case, it was one synthetic data set, but it could also have been multiple data sets from different clinical systems combined together. And they might have had to do some standardization around code systems and patient indexing, but because all the data is in FHIR, it's easy to query across. And so in this example, I ran a care management type of query around looking at blood sugar control and joined it to the patient table and was able to run a query across these 1.5 million patients in just a few seconds because Google BigQuery ran spun up a number of servers to run the query automatically. And so this is an example of the types of things you can do if you have the ability to move around bulk data. So I'm going to end there. If you download the slides, I put in some resources on where you can get more information on some of these topics. And I'm going to hand it over to Linda to talk a little bit about some of the actual use cases for these technologies that she's worked with.
Thank you, Dan. If you could move to the next slide for me, please. I think you guys are driving the slides for me. Thank you.
I'm sorry.
On this slide, I just want to acknowledge that I have borrowed some slides under the gracious donations from Scott Naris and Ken Kawamoto, both colleagues of mine, who have also been very involved in using FHIR to build applications at both Intermountain Healthcare and the University of Utah. Next slide, please. The first thing that I want to talk about is kind of Intermountain's tagline. Why do we care about all of this IT stuff in healthcare? And it really is to get to helping people live the healthiest lives possible. Next slide, please. But we do have a lot of challenges in that area, so that we have, only about 55% of our patients are receiving the recommended care. And we have as many as 440,000 people dying each year from preventable medical errors. This is really kind of astounding and something that we really need to pay attention to. And this is the tool in an area that we can start addressing that. We know we have high costs in our healthcare, and that our physicians are spending a lot of time on things other than direct patient care, and not just the physicians, but nurses as well. And so we're really looking at how these interoperable apps and services could help us address a lot of these challenges. Next slide, please. So many of you are probably familiar with what's on the left. This is what we live with today. We have a lot of direct interfacing between our different applications and EHRs and stuff that we want to be doing. But we really have this vision for what it could be tomorrow, a very much plug and play interoperability, which Dan has given you some more details about and Russ alluded to in the beginning as well. Next slide, please. So again, just another picture. Imagine if it didn't matter what vendor you were using in your hospital or at home. This is not just hospital-based healthcare anymore. There's a lot of things happening in a lot of other healthcare areas besides a hospital. And so imagine if you had a healthcare app store where you could reliably go and find an application that would help you accomplish what you wanted to be doing. So the next slide, please. And so at Intermountain, we've always been very interested in our decision support and what we can use our systems to help the clinicians. And this is just a listing of a small list of things that can be done through decision support to help clinicians provide better care. Alluding to what Russ had said earlier, we as humans can only manage so much in our brain at one time, and there's so much data coming at all of our caregivers in any given day or with any given patient. So the next slide, please. We know that at Intermountain, we have had in our legacy system upwards of 150 different decision support rules or modules. But we know we've also only picked the easy stuff. We've only done the stuff that's either low cost to implement or easy to do. And there is a lot more that we'd like to do. We have estimated up to 5,000 or more different decision support modules that we could be doing to help our clinicians provide better care. However, we have not had a good way to get from the 150 that we have to that 5,000 plus. And so we're looking at how we need to really fundamentally change this ecosystem of our healthcare IT. A little bit about Intermountain. You can read this on the slide. We have 23 hospitals, more than 185 clinics. We have a really strong history of innovation in informatics. We had our own homegrown solutions, both inpatient and outpatient, up until just a few years ago, where we just have had a contract with Cerner and have implemented Cerner, finishing that implementation just in the last year. Next slide, please. In our contract with Cerner, we, at the time of even going with a vended system, said we need to create an ecosystem that could allow us to have open standards-based APIs. This is how we see the future to being able to support all the different needs that our caregivers need. We know that each of the vendors are really maxed with what they can do, and they're doing a great job at what they have, but no one person is, or one company is ever going to meet this demand. So next slide, please. Coincidentally, around the time that we were partnering with Cerner, FHIR was also coming out, and also Smart. And so we had quite an opportunity to be able to use FHIR and Smart on FHIR to create lots of different things. So the next slide, please. Since we have implemented Cerner, and while we're implementing Cerner, using FHIR and Smart on FHIR, we have accomplished creating some FHIR development and production servers. We have a few technical things on this slide that you may not care about. We have integrated some smart apps in iCentra. A couple of them were somewhat on demand of our clinicians, even to get iCentra in. iCentra is what we call our implementation of Cerner, I forgot to mention. And one of those I'll describe in just a minute. So we have part of our implementation, we included 3 Smart on FHIR apps, and we have a 4th one currently in development to be implemented at Intermountain. Through those implementations, we've been able to share our enhancements across those applications with other organizations in the EHRs. And we've also done some other development with Cerner, and also getting a development environment and a sandbox. So now our one example that I'm going to share from Intermountain today is the pediatric growth chart. This one was developed by Boston Children's. It was something that was desired by our clinicians. They felt it was better than what Cerner had to offer. And next slide, please. It is an open source standalone or integrated. We integrated it in. It uses data from our EMR, which is the height and weight, length, head circumference, BMI, and also the date of birth, the gestational age, sex, etc. And we currently have this in all of our NICUs and pediatric clinics, and replaced our Cerner module with that. Why did we do that? Next slide, please. It is a very concise, interactive view. It was much more palatable to our clinicians. It includes a lot of the different charts that are used for pediatric growth charts, the CDC, the WHO, the Fenton. We're able to update it and do things. We can also use it for gestation corrections, our bone age presentations, and we have printouts that we can give to the families and the parents. Next slide, please. This is just an example of what that module looks like within Cerner. So you can see the top banner is Cerner, the left navigation, but all of the screen, the meat of the screen is all of that uploaded and embedded, integrated Smart on FHIR app. What did we learn through this? We learned a lot. I have a few slides on that. One is that the vendors do provide a fairly extensive set of FHIR resources, but they are still somewhat cautious and conservative. They're not exactly sure how much this is going to catch on and how much they should be putting forward towards this. So they're there, they're paying attention, they're doing it, but it's not as fast as we'd like to see. And we also know that we need some more support for different use cases, specifically around write capability. And that means if I create something in the Smart app that I can write it back to my EMR, that's one of our harder things to do right now. Next slide, please. We still need some expertise on our end related to the vendor data. And that is because when we're working with the Cerner data, and this is true with different vendors, you know, they're created their data in a way, and for the app developers and people from our institution, they're not always sure where the data is, what they call it, and if you're going to get back what you're asking for. The third slide around lessons learned. One thing that we've also learned is that there really is a lack of specificity in our FHIR resources. We know that FHIR resources need to be profiled, and we have the US core that has been profiled, but it has not been enough. We know that we need to do more work around really what are the terminology bindings and things that happen. So it's getting closer and it's helping a lot, but we still need to keep working towards it. And then the other thing that Dan just covered very carefully and well was around the single patient versus population base. We need single patient, yes, but population base is just as important as well. And the next slide, please. The other thing that we know, and I said, is that these differences in vendor implementations, the data models and the way they search and approach their data is not insignificant, and something that we are addressing as we go along. And just a real quick slide, and I won't spend much time on it, next slide, is what do I mean by these differences in data? And if you look very carefully at this, different ways they store the data. So you can have suspected lung cancer, and each one of those data elements can be stored its own, cancer, lung, and suspected, or they can be coordinated in multiple different ways. So I could store it as suspected cancer, the body site lung, or I could store it all as just one data item, suspected lung cancer. And that's one thing that we're running into as we look at implementing these Smart on FHIR apps within the EHRs is the apps may have it one way and prefer it one way, but you get into the EHRs and they all have their way of preferring and their way of doing it as well. Next slide, please. And I'm also pleased to be able to tell you that I can share a little bit about what's been happening at the University of Utah. Next slide, please. So they have these 6 apps that they have implemented, and I've given you small little tiny screen prints over on the right that you can kind of see what they're like. But they have from the neonatal bilirubin app, and that one's where it's looking at mother and baby EHR data. And they've implemented, and they're estimating that they're saving over 300 physician hours a year by using that app. The procedure capacity management app, this is really a calendar item that allows them to see what is their capacity versus the scheduled procedures. The surgical referral dashboard, this is supporting any post-surgical care transition, and it's one of the ONC high impact pilot projects. The diabetes treatment outcome prediction, this is in collaboration with an external company, Hitachi, and it's really looking at what prescription guidance needs to happen for your diabetes outcome. Opioid decision support is also included, as is the MD Calc integration. I'll keep going in for time. So at the University of Utah, they have this vision called Reimagine the EHR, that the EHR is a joy to use. The EHR is constantly saving time, leaving more time for patients and the family. There's no need to hunt through the record. Everything you need is right there. It's easy to do the right thing every time. And when you imagine how the EHR should work, it really becomes that that's the way how it does work. And we like to say at Intermountain that we like what they've called out there and we support that. But we do know that there's some challenges in that. And I've kind of listed those in our lessons learned, but interesting to see that there are some of these that are similar at the University of Utah. We need to have additional FHIR APIs. Things that we have are good and we're glad to have them, but we need to keep working and improving those. So the top-down approaches, such as the US Core FHIR Profiles. We also need to be working on the bottom-up, where we create our FHIR profiles and share them as well with their implementations. We need to tighten our standards and improve conformance testing around how they're implemented with different vendors. We need to define our core logical data models and map them to the different types of FHIR, meaning that FHIR, as Russ indicated, is still under development. So we are dealing with kind of running with this car and changing the tires at the same time. You've got different maturity levels between the 2, 3, and 4 in flight and being used. It's a challenge, but we're working through that. And then also, healthcare organizations are often very much looking at their own organization. And in order to make a lot of this work, we really are going to need to promote some collaboration amongst different healthcare organizations. So now I have just a couple slides. Next slide, please, is talking about the rationale. We know that if we do this, and we keep going through these FHIR-based innovations, it helps us tackle these really important problems that are hard to do. We can move from our current ask and hope to the EMRs to actually accomplishing and making it very feasible to get some of the decision support and help that we'd like to see come out of our computer systems at the bedside. We can harness the innovation of many, many people. It doesn't have to be just a few places. And also there's a potential commercialization around this and the potential to get some externally funded R&D. We also know that it's a much more, next slide please, very efficient software development, and we have a very increased choice in software. You don't have to have just one vendor's interpretation of that neonatal bilirubin. You might have 5 different ones that are implemented in different ways, and you could choose, each one of them being adequate and very good in what they do, but it just maybe fits better for your clinicians, your site, something like that. And we also know that this is really the beginning of really meeting the learning healthcare system. So the next slide. What I really just want to say is that interoperability of these applications is still in its early stages. We know that the models and profiles are different, and they limit interoperability if we don't give it specific attention, and we're starting to do that. One note of caution, open source apps are not always free. It really does take some time and energy and investment in getting them to work in your local institution, but we do believe that the more we do this, the less expensive it will get over time. Prioritization and governance are key as a community. We will need to work on this together. And this prospect of this new ecosystem to support our vision is real, and it's really worthy of our investment, because again, we get back to that we really are just trying to help people live the healthiest lives possible. And my last slide, I just want to acknowledge all the people on our team. I don't do this in a vacuum by myself, and so I just want to say thank you to everyone who contributes to our progress and my learning and knowledge, and I think we're ready for questions.
Thank you so much, Laura. That was really helpful. I think it's great to hear from somebody who's kind of out there on the front lines dealing with this day in and day out. And Russ and Dan, thank you so much for your presentations. It really explained that in plain English for someone who's not a techie. I thought that was really easy to understand. So thank you to both of you. We've got a number of questions and we've got a few minutes here. So why don't we go ahead and try to work through some of these. The first question we had was around FHIR and PHI, and whether or not FHIR is actually, can it help you meet HIPAA standards? And Dan, I don't know if you want to take that question.
Sure. So I think FHIR provides the building blocks to meet HIPAA standards. I don't know that it's directly addressed. So FHIR provides the standard data models, a standard way to access the data, and standard security. And then you can use those things in terms of complying with HIPAA. So making sure that the people accessing your applications that use the data have the correct authorization to do that.
Yeah, and I think it helps that Smart on FHIR is inherently about one patient. You're not logging on to the EHR system. You're seeing the data of one individual. That doesn't mean there's no potential for somebody to fake who they are, but it does help with the HIPAA compliance.
Great, thank you. And there's another question about, several questions about HL7 and Da Vinci use cases. And Seth, I don't know if you want to, or Dan, I don't know if you want to take that. We had several different questions about how provider EMRs are integrated with healthcare systems and using FHIR and how those integrations were done. Dan, do you want to talk a little bit about that?
Sure. So I'd say we're still kind of in the early days of those types of integrations. And the Da Vinci project came up. That's an effort by a group of payers and EHR vendors and other folks who are trying to figure out standardized workflows, building on top of some of the things we talked about, Smart on FHIR, CBS hooks, and then the core FHIR specifications that Russ and Laura had talked about, including profiles. And so I think those pieces are starting to come in place, and people are probably doing pilot and early stage work around it, but I don't think there's really good standards or implementation guides for making that connection. And then the other piece I would point out is that one of the big use cases for the bulk data effort, which is also in the very early days, is around moving data between providers and payers in both directions. So payers want to get clinical data from providers to calculate quality measures and help guide care for the patients that they're covering. And then providers want to get data, claims data from payers to help understand where patients are, the care patients are getting outside of their system. So I think there's a lot of good stuff coming, but it's still pretty early days.
So for those of you who do not know, the Da Vinci project is sometimes described as Argonaut for payers. It's around value-based care use cases. InterSystems is a member of the Da Vinci project, and we're very excited about it because of its potential to accelerate value-based care.
Great. And Laura, there's some questions about Intermountain and how you actually identify areas for innovation. Are you focused on specific patient conditions, or were there certain individuals that were championing them? Is there kind of a rhyme or reason to that?
Yeah, we definitely have a committee within the hospital system and within our organization that looks at all of the incoming projects and look at prioritizing those. And it really, quite frankly, initially during the iCentra was down to where's our biggest impact for the time we have available to get, some of the things done to get it in for the implementation. But we definitely have a committee wrapped around that.
And just as a follow-up to that, are you doing any work around, or considering doing any work around optimizing medications or medication reconciliation? Any comments about that?
I don't know of a near-term project on that. I do think there is a project on our kind of an incoming list, but that has not been prioritized yet.
Interestingly, this is Russ. One of the first Da Vinci project use cases was 30-day medication reconciliation, which actually was the first use case and has been completed. So hopefully that will drive more work around medication reconciliation in clinical situations.
Ah, great. And then I'm not sure who could answer this. Russ, maybe you can. How do the standards handle specialized data? For example, with CHF patients that are evaluated based on posture in bed, or dementia patients, evaluated based on nighttime activity. Can, patient-generated data for some of these specific use cases be handled by the systems? How does that work?
Well, yes, patient data can be handled, but the answer to that question is very complex, and it applies not just to patient-generated data, but it relates to the need to identify the specific FHIR profile that fits the use case, and there are codes for things like the posture of a person when their blood pressure is taken, and that affects the blood pressure. So those things for detailed use cases do need to be part of the FHIR profile specification to meet that use case. There's a lot of work to be done there, but we have started on that.
Great.
Well, and Russ, I would just add, this is Laura. This has to do with CIMI, the Clinical Information Modeling Initiative, and I know there's some questions on that. We did not bring CIMI into this discussion today, but it is part of what we talk about heavily with the FHIR profiling. And CIMI really does address a lot of what we're talking about with that specialize in the modeling based on position, et cetera.
We have just a couple more questions, if I can keep you for just a couple of minutes longer. I know we're at 3, if that's all right. A couple of quick questions here. One is about, can you talk a little bit about the plan, or the plan to push around the regulations that support consumer-driven healthcare? Do you feel like they're trying to kind of force the hand of healthcare organizations to connect to smart apps? Any thoughts on that or comments on that?
I think smart apps have momentum because they meet needs that haven't been met in the past. I don't think it requires regulation. I think it's driving itself because people are able to do things with FHIR and with Smart that they couldn't do before.
I think that's true, and I would add to that there is some regulation that's probably helping to drive this. So a lot of the Argonaut project effort, which resulted in Smart being put into some of the EHRs, was really driven by the patient API access requirement that was part of meaningful use stage 3. And so that doesn't specify that Smart on FHIR be used as the API, but a number of vendors have standardized on that. And there's currently regulation being drafted under the 21st Century Cures Act, which was passed in 2016, which also requires API access to data. And so that regulation may also, hopefully will drive additional use of these open standards and providing patients access to their data to do what they want with.
And I think the other important thing about the 21st Century Cures Act is it provides a significant amount of funding for these efforts, because the regulations are one thing, but being able to have the funds and to stand up projects to make all of this happen is something else. And the 21st Century Cures helps in that way a lot.
And what about 2 final quick questions for you guys? When a vendor says I'm FHIR compliant, what does that mean?
Yeah, that's sort of like when your box of cereal says it's low calorie and heart health. I don't know what that means. It's a sales logo, I think.
Yeah, I'd agree. I think it's important to try to understand exactly which versions of FHIR they support, which data models, so which FHIR resources they support, whether they support just accessing the data, whether they support search and in what forms, whether they support the ability to write data back to the system. So there's kind of a lot of nuances, and depending on your particular use case, the vendor support may be sufficient or not. So I think saying that they support FHIR isn't quite enough. There needs to be more analysis.
And as Laura mentioned, the need for conformance testing and programs to actually certify that somebody is compliant with some specific FHIR specification. That is something that HL7 is working on, that I think is much needed, and is part of the work that's going on that will make things certainly more interoperable.
Great. And Russ, we have a couple of questions. People they loved your presentation and want to know if you used Prezi.
I did not use Prezi. A graphics company that InterSystems uses for producing some of our presentation content does a drawing based on listening to me do a presentation. They do a drawing of what I'm talking about, and then they turn it into a video. And I cut that video up into little pieces and put it on PowerPoint slides, and it comes out very well. And I take no credit for the artwork or creativity. My chronic art deficiency was identified by my 3rd grade teacher, and it hasn't improved. I can't take credit.
I'm going to give you all credit, because this was a really wonderful session today, and you, I think, put this in very plain English for many of us and did a great job explaining it. So Laura, thank you for sharing your direct experiences and your lessons learned. And Dan and Russ, thank you as well. We appreciate it. If you're interested in learning a little bit more about this, or FHIR or Smart, feel free to go to the InterSystems website. Russ and Dan are doing a lot of work on this, as well as Laura and Intermountain. So feel free to reach out to them here. We did get a couple of other questions that we were not able to answer. We're going to be putting together some Q&As to distribute shortly for folks on FHIR, so we will get those out to you as well, and the slides are available online. So thank you again, and thank you to InterSystems again. Thanks for hanging in with us a few minutes longer today, and appreciate everybody joining us. Have a wonderful afternoon.
Yes, thank everyone at EHI for producing this, and Laura and Dan for agreeing to help me out and put this together. Thanks.
Fantastic. Thank you.
Thank you.
All right.
Thanks.
Bye.